Hello, good afternoon, everybody. Welcome to my anal stream. Welcome to my anal stream on YouTube. And I want you all to know, this is only part 1. This is part 1 of the anal stream. There is a part 2. Initially, like, this was supposed to be just one stream about this topic, but when I got to when I got to the topic of anal cancer, it's more complicated, so I have to cover it in another stream. When it comes to cancer, I'm gonna become more thorough when it comes to cancer now. I'm not gonna do it briefly or like cover it like only. I'm not gonna cover it briefly. I'm gonna do like almost full coverage, kinda. So I decided to separate cancer from this. May quiz ba sa muda? A quiz? Gusto niyo ng quiz? Sige, of course there will be a quiz. Okay, class? Class, may quiz mamaya, so makinig kayo. Practicals, yes, we will have practical exam also later. Don't worry. You have to choose your partner later, okay? Alright, so a lot of you were asking, asking in chat what this is about. So this is about going anal. This is about anus. Specifically, this is part 1, so I'm only gonna cover the most common surgical diseases of the anus. Okay. Okay, guys, so I did this topic years ago. Like, if you scroll back on my medical education playlist, like years back, I did a coverage on anus, but it was more, it wasn't as in-depth, so I'm gonna do it a little more in-depth this time. That's why I had to make this part 1 and part 2. Part 1 is benign diseases, part 2 will focus on cancer, okay, because that one is a lot more complicated. Okay, oh wait, let me wear my glasses. Gotta wear my glasses. There we go. This is gonna be it. Okay. The last anal was not. Yeah, it wasn't in depth, so we're gonna go more in depth. We're gonna go more anally in depth this time, okay, guys? Alright, so. Let's talk about the anatomy of that special area in your bum, okay? Okay, chat? So, here we go. This is a not a cross section. It is a sagittal section of your anal area, okay? So, imagine being sliced longitudinally. This is what it looks like, okay? So you can see the butt hairs right here. These little strands over here, these are your butt hairs, your anal hairs. So this is the outside. Okay. And then over here you have specific muscles here. The important muscles we're gonna focus on are your anal sphincters. Okay, so you have your external sphincter, this one. And then you have your internal sphincter, which is this one. So look, the external sphincter covers the internal sphincter. Okay? Now, the internal sphincter the external sphincter is one that you can control. Okay? You can voluntarily control it. So when you clench your butt, you're actually controlling your external sphincter. So try clenching your butts right now. Try clenching it. You're actually contracting this one right here, your external sphincters, okay? That's your butt clenching muscle. Alright? Because the internal sphincter, you can't control that. That one is controlled by your body. Involuntarily. Doing it right. Okay, everybody. Okay, class. Yan yung ano. Practicals. Okay. Practical, ano. Clench your butts. Okay. Alright, so, this over here, this space here, or the hole, this is the, over here pala, ito, at this point, this is called the anal verge. Okay, and then we call this tube, or this canal, the anal canal. Sino magla-live demonstration? Mamaya na yung live demonstration, okay? Okay, so kunwari, ay ito, and then we have two types of we have two classifications of the anal canal. So we have the anatomical anal canal, which is just this, which is basically until here. This one over here, this is the dentate line, by the way. This is the we call this the dentate line, and it contains the anal columns of Morgagni. I actually have no idea how you pronounce this. Morgagni. Anal columns of Morgagni, or the crypts. Okay? There's crypts in there. There's crypts in these columns. Alright? And then at this point over here, below the dentate line, that is the anatomical anatomical anal canal. But surgery-wise, it goes a little beyond that, above the dental line, the dentate line. Okay? Mamaya sa Discord. Alright, and then let's see what else do we need to. Okay. It is also important to know that this part, you see this part, this pinkish part of your anus, from here, until this part, this is made out of squamous epithelium. I don't know, are you guys familiar with squamous epithelium? I don't remember if they taught this in like biology in high school or so, but are you guys familiar with epithelial tissues like squamous epithelium and ano to? Columnar. Oh no, okay, some of you don't know. Okay. The skin, okay, or not just the skin. The parts of your body, they're different. The coverings of organs in your body are made of different types of epithelium, okay? These are the cells that line the outside, that line a certain organ. So your skin, your skin right now is made out of squamous cell epithelium. Squamous cell, they're like flat cells, okay? And then, if we go to here, the rectum or the anal, or no, rectum, they're made of columnar epithelium. So squamous cell epithelium are like flat cells. Columnar are basically like columns. That's why they're called columnar. There's also such thing as cuboidal cells. They just look like cubes. Okay? And then there's also the ano to? Wait lang. Nakakalimutan yun na if keratinized or... Keratinized and non-keratinized means like basically dry. And then non-keratinized is like wet. That's how you remember it. Okay? My school health class where I don't remember I don't remember if they taught this in biology in like high school or so. Probably not. I probably mixed up my biology in high school with biology in college, so I think I learned this in college, not in high school. I may be wrong. Okay. I know that. Yeah, there's like unfortunately I don't have slides about the epithelium. I think I can cover that in the next education stream. Yeah, they didn't. Yeah, okay. Anafi. Yeah, okay. Yeah, it was college. Okay. Yeah, they taught us the different cell types. Okay, so if you took biology or had a course similar, they teach you about the different cell types. Okay, so yeah, that's histology. So basta, all you need to know for now are squamous cell epithelium and columnar cell epithelium, or columnar epithelium. Okay, squamous is the one. Squamous cell epithelium is your skin. Okay, your skin, your skin is made of squamous cell epithelium. And then if we're gonna talk about the guts or the rectum, it's columnar epithelium. Okay, that's all you need to know for now. We can probably get to like more specific with the cells in another stream. Okay, what else? You see, okay, you see these blue spots here? These blue spots are called the hemorrhoidal cushions or hemorrhoidal piles. Hemorrhoidal cushions, piles. These are actually normal. Okay, it is normal for you to have hemorrhoidal cushions in your anal area. So, what are hemorrhoidal cushions? They're actually blood vessels, veins, blood vessels. Okay, like a pile of blood vessels in an area. They just hang out here, like a bunch of blood vessels hanging out right there. Okay. Yeah, you got cushion. Yeah, that's what they say. You know, they say these hemorrhoidal cushions help with what do you call this? With defecation and like, you know, opening and closing the anus. Okay, so it's just imagine like your anus. Okay, you contract your anus or you clench your butt when you're trying to like make when you're contracting your butt. You have cushions inside your butt. Imagine them as little pillows. You got tiny little pillows in your anal area. Tiny little pillows made out of blood vessels that are ready to burst and bleed. Basically, okay. Alright. So what are hemorrhoids? I'll get to that later, okay? I'll get to that later. Alright, I think that's all for anatomy. Rectum, this one. Anything above this anal canal is the rectum. For surgery, the anus is up to 5 centimeters from the anal verge. Okay, so it's around here. Anything above 5 centimeters is already part of the rectum. So that's for surgery. Okay? I think... yeah, that's all for the anatomy. Oh, here we go. Remember this also. Squamocolumnar junction. This part is made out of squamous epithelium. And then when you go above here, they turn into columnar epithelium. This is important. Okay? This is very important. Squamous, columnar. Squamous, here, columnar. This is the junction. Alright? Alright! Guys, what is the purpose of the anus? Okay? Class recitation. Let's have an oral recitation. What is the purpose of the anus? Anong purpose ng anus natin? Let's see. Let me call... do I call any volunteer or do I call out people? Sino tatawagin ko? Sinong tatawagin ko? Bread! Bread! I don't remember my butthole looking like that, bro. Bread! What is the purpose of the anus? Ikaw na lang, kasi bread yung tatawagin ko. Bread, what is the purpose of the anus? Purpose of the anus if it's a guy. Hoy! Ibang purpose yan. Ibang purpose yan. Oh God. Bastos, itong si Bread. 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 Well, that kind of a purpose is for the after hours. Okay. Let's see. Anyone exit ng dumi to hold feces before defecation. Yeah, defecation. Okay, yeah. Okay! This is the purpose of the anus. Poo-poo. Stool. Tae. Ebak. Defecation. Hello, Morphe. Welcome to the anal stream. Kakapasok lang, tanog ka agad. Late ka eh. Ganun talaga. Late ka. Okay. Alright. Basically, yun naman talaga. Yeah, basically, yun naman talaga ang purpose. Your anus is what controls... Okay, it's for defecation. It is what controls what goes out of your butt. It controls your defecation, your flatus. Flatus is the medical term for fart or utot. Okay? Flatus. So, your anus is what regulates it. If your anus doesn't work, you're either going to be having diarrhea or defecating every time you walk or even sit. Or you don't defecate at all because your anus is just contracted, it doesn't relax. Okay? So the anus has a very important role. If you remember, for those who were in my first membership stream, or for those who watch Cells at Work, remember that scene where the father had to like hold his poo? Remember that? So that was like a representation of the sphincters in action. Okay, and then you have some RBCs running around there because he has hemorrhoids, yeah? The sumo sphincters, yes. So imagine they actually showed two types of sphincters, right? They showed two types of sphincters. They had the sumo sphincters, and then they had the other sphincters, right? So one represented I think the sumo ones represented the I think the sumo wrestlers represented the internal sphincters, and then the other ones were representing external. Okay. Alright, bakit may silent and loud parts? Depende sa gaano kadaming utot na nasa ano mo. Yeah, the inner, yeah, okay. Sumos and rugby boys. Yeah, so one was represented internal sphincter and then the other was external sphincter. Okay. Alright. Okay, next. Okay, physical examination. When doctors examine your anus, we do a digital rectal exam. Okay? So, I think this is also done in some, annual physical exams. I think this is done in some annual physical exams. So, they do a rectal. So, how is it done? Okay, how is a digital rectal exam done? Usually the doctor or there's two positions you can do this. Either standing up and bending over or lying on the side. Okay? For me, I prefer the patient be lying on his side. Because that way he doesn't stand up. Sometimes they just stand up and get all stiff and just stand up from bending over. I'd rather do it on the side, and it makes them more, I think they're more comfortable that way. They're on a bed, so. Okay? So, what they do is that, if it's lying on your side, so if it's standing, you're bending over. If it's lying on your side, you have to be in a fetal position. You have to be like hugging your knees, or your knees are to your chest, okay? So that your anus sticks out. And then what the doctor will do is they will use gloved hands. They better be using gloved hands. Imagine if they're not using gloved hands, okay? That is disgusting. Their hands will be gloved. They will put a gel or a lubricant on their finger, okay? And then they will... The first thing that they will do before they insert the finger is to examine how your anus looks like. Because sometimes you can have masses or hemorrhoids on the outside, okay? Or those are called external hemorrhoids. They can check if there is like blood stains or anything, if there's other lesions. And then, after that, they will start palpating. They will insert the finger and start palpating all around, okay? They usually, for what they will feel the sides. So they expect them to rotate their finger a bit because they need to feel all sides. Like it says here, the left wall, the right wall, the anterior and the posterior. Okay? For men, they will feel your they will feel your prostate, which is found anteriorly. Okay? So here, they will feel it. And if it isn't and normally, okay, if your prostate is normal, it won't be that prominent. But if you have a large prostate, we'll be able to feel it. And we can also tell if it's smooth. If the prostate is smooth, then that's a good thing. But if it's not smooth, like it's rough or bumpy, then that says something. There's something wrong with your prostate. Okay? For women, usually what we can feel anteriorly is the uterus. Especially if the uterus is enlarged or there's may bukol, we will feel that. If there's a mass, we will feel it. Okay? Why is my brain going all over the place right? But I won't go. We are talking about digital rectal exam. Going in dry, that is gonna be painful. What if it's naturally big? What do you mean? What is naturally big? What is a prostate supposed to feel like? It feels like a rubber ball. It feels like a small rubber. It feels like a rubber ball inside. I don't know how else to describe it. Like if the larger the prostate, the larger the rubber ball is. Something like that. Wait, how do you document this? What do you mean? Like write it down in the physical examination? How we write it down? Is that what you mean? We say in medicine, we go by 5. About 5. There's an order of doing a physical examination, right? Observation, auscultation, palpation, percussion. 4 pala, hindi 5. Am I missing anything there? Observation, auscultation, palpation, percussion. I think percussion's the last, if I remember correctly. So, obviously, you can't auscultate the anus, so you can skip that. But see, observation, like I told you. Observation, you look first before you insert your finger. You don't need to auscultate because there's nothing to auscultate there. Palpation, that's when you put your finger in and palpate. Percussion is also not needed in examining the anal area. Okay? So I'm still year level 1. Oh wait, are you in first year med school? Wait, are you first year med school? How strong do you have to trust the gloves so they don't rip? They typically don't rip, Chrysostom, Ibarra. They don't rip. The anus is not sharp. It's soft and squishy and blunt. It's not gonna rip. Yes, okay. Oh, okay, you're in year level. Yeah, they will teach you. Don't worry, you'll get into that. They will teach you the order of physical examination. So it's inspection or inspection or observation. Okay, inspection or observation. Auscultation, palpation, and percussion. I think percussion is the last one before after palpation. Okay. So, what if the patient requests percussion? They don't request for that. To be honest, percussion is rarely done. But for spectral anomaly, you're in your first year med school, you're gonna do everything they tell you. Okay? You're gonna do everything in detail. I'm telling you as it is. When you're a med student, everything you do is gonna be in great detail. The higher up you go, so after med school, you're gonna become a junior intern. You're still gonna be in detail, but it's gonna be a much less than it was when you were a med student. And then senior intern, it's gonna decrease until residency. You're doing shortcuts already. Yeah, I'm telling you right now. But as a med student, do everything as they say. You're gonna be doing everything in great detail. And yeah. Alright. Okay. I think that's all. Yeah, that's all. Another examination done is a proctosigmoidoscopy or an anoscopy. Okay? A proctoscope or proctosigmoidoscope is basically this. It is a long metal tube that you insert through the anus and into the rectum. If it is a proctosigmoidoscope or a proctoscope, this is usually 25 centimeters long and it reaches the sigmoid column. Okay? Ito, ayan pala. Ito, rectoscope or proctosigmoidoscope, it reaches 25 cms. There's a shorter one called the proctoscope, 13 cms. Anoscope is 10 centimeters. Yes. Okay? So, this is like a mini version of a colonoscopy. Because colonoscopy goes all the way to your cecum or the ileum. Okay, the terminal ileum. This one is just covering up to the sigmoid colon. So what is the purpose of this? It's to visually see what's inside. If there's... Because, you know, in a digital rectal exam, your digital rectal exam can only go as far as your finger, as how long your finger is. And my finger that I use for digital rectal exams is like... What is this? 4 centimeters? I think my... I think my finger is like only... 4 centimeters. 4 to 5 centimeters long? Yeah. I have a short finger, actually. There are some doctors that can feel stuff when they do digital rectal exam, and I don't feel what they feel because they have longer fingers. It reminds me of the horror game you played before. Oh yeah, that one. Revenge of the Colon. Not the middle finger. No, you can't use the middle finger. You use you'd use the pointer finger. Or the second digit. Okay. Paano kung naka-slay nails ka do? You know, as doctors, we can't have that. Especially surgeons. We can't have that. We cannot, have nails. Surgeons? Female surgeons cannot have those kinds of nails. And if they do, they have to remove it when they do examinations or when they have surgery. Because, you know, it's not compatible with our jobs. Unfortunately. You can't slay. No, we can't slay. Only females. Ewan ko, kung merong lalaki na ganon, it's the same thing. Okay? Anyway, so yeah, this is just to see further away, visualize the anus, okay? Because in a digital rectal exam, you're only relying on tactile stimulus, or what you feel, but you can't see. So that's what this is for. So in a digital rectal exam, what you're gonna be looking for is, or what you're gonna be feeling for, is if there are any masses. Okay, see hemorrhoids, for example. If there are any fistulas. And when you pull out your finger from the digital rectus, we also look at the finger because we need to see if the stool or the poop, what color is it? Is it red? Is there blood? Is the poop black? What color is the poop? Is it brown, black, red? We have to take note of that. That's part of our physical examination. Okay. Alright, next. Diseases. Okay, we're gonna go to benign diseases of the anus. Alright? You guys have any questions? Chat. Hello, Milk Shakespeare, and welcome to the anal stream. At least, anal stream part 1. Any questions, chat, before we move on to the diseases? If none, we're gonna move on. Okay. Alright! First one, anal warts. Okay? So, yeah, I went with the old slide because, you know, getting photos of if you want to know what actual anal warts looks like, just Google it because it is disgusting. Okay? Just imagine cauliflower or flesh-colored broccoli in your anal area. That's how it looks like. That's what it looks like, okay? Just Google it. Look, Google anal warts. Okay, so just imagine the supporters here are the warts, okay? Supporters are... Yeah. Okay, just imagine these are the warts, okay? Is this HPV related? Yes, it is. It is actually STI related, specifically and more commonly HPV. Okay? These are most commonly... This disease is is very common in men who like to be on the receiving end of other men. Okay? So yeah, just Google it, okay? Anal warts. HPV anal warts. You'll see it. It's gross, okay? Look at it uncensored. I did not put the photos here because trigger warning. It's pretty gross actually. Yung purpose na sinabi ni Brett, yes. Okay? So, I've had patients who had this, and it's more disgusting to look at than hemorrhoids. Okay, hemorrhoids are like nothing to me, but anal warts, it literally looks like either looks like cauliflower or broccoli sprouting from your anus. That's what it looks like. Okay, especially when there's a lot of them. If there's a lot of them piled up there, that's what it looks like. Okay. Alright. Next. So, treatment. There's topical creams for this. Okay, like imiquimod. Although, for us surgeons, we don't really prescribe this. We just straight on operate on them. So, we do a procedure called fulguration of warts, or we just burn them with an electrocautery. Okay? We burn them all. Burn every single one of them. If they're really big, then we have to excise them, but then we have to burn the root. Okay? Because they're gonna grow again. Okay? If they're large, we excise, but then we have to burn the root. Okay? Like footwarts. Yeah, pretty much like that, but footwarts are tame. Anal warts are a lot nastier. Okay? Alright, hemorrhoids. Okay, this one is a very common. This one is very common. Okay? This one is a very common disease. So hemorrhoids are engorged blood vessels. So remember I said that it is normal to have hemorrhoidal cushions inside the anus. Now if these cushions engorge or get large with blood, they inflate or they prolapse like this. So we have two types. There is the internal hemorrhoid, which is hemorrhoids that are above the dentate line. If the hemorrhoids down here are below the dentate line, those are called external hemorrhoids. Okay? And here's another presentation. So, internal hemorrhoids, external hemorrhoids. Okay? Is the patient conscious for the procedure? For fulguration of warts, it's usually done, depending on the size usually it's spinal anesthesia. Depends on the size. It can be done in local if it's like small and it covers a small area, but if it's like surrounding the entire anus or like really large, then under spinal anesthesia. Is there any cause on why they inflate like that, causing hemorrhoids? Okay, yeah, there are certain causes for getting engorged blood vessels on your anal area. One is when you carry heavy stuff all the time. So, carrying heavy stuff all the time, coughing all the time, straining all the time, like when you try to pee and you, alam mo yung umiiri ka? Like really, putting force into to pee. Constipation also. Constipation because umiiri ka. So, and also diarrhea when you have lots of diarrhea. So, and also when you sit down too long in the toilet. So, kayo dyan, which one of you guys, I'm pretty sure there are some of you, pag nasa bahay kayo, nagsa-cellphone, nanonood ng stream ko, nakaupo sa toilet, tumatae. Nanonood ng stream ko. And you end up watching my stream all the way while you're still sitting in the toilet. You're putting yourself at risk for getting hemorrhoids. Okay? Ano? Sino na-call out ko dyan? Sino dyan tumatae dyan? Sino nasa toilet ngayon? Mobile Legends. Ayan. Kayo, yung mga nakaupo lang sa toilet ng matagal, nagse-cellphone, naglalaro ng Mobile Legends, o naglalaro ng Nike, o nanonood ng stream, tagal-tagal nakaupo, ayan, okay, you put yourselves at risk for getting hemorrhoids, especially if you do it for a long time. So don't be surprised kung may nakalawit na sa puwet nyo, okay, after a while. 5 minutes pa. 5 minutes is long already. Okay. Alright. So, here we go. Ayan, oh. Okay, next. Here we go. Ayan, there. External hemorrhoids. Okay. First, external hemorrhoids. They are below the dentate line. So, this is the dentate line over here. External hemorrhoids or hemorrhoidal cushions, hemorrhoidal tissues, hemorrhoidal piles. When they engorge, they become external hemorrhoids. They are painful. Okay, and like I said, squamous epithelium. The external hemorrhoids are the ones below the dentate line, near your anal opening, and they are painful. They are painful. The reason why they are painful is because this part of the anus, like I said before, is made out of squamous epithelium. Squamous epithelium, or this type of skin, has a lot of nerve endings. So this is the one that's really painful. Like, konting like one touch lang masakit yan. Okay? Now, if you have internal hemorrhoids, which is above the dentate line, so here, and then they're just prolapsing or they're just swollen, it is painless. Most of the time, it is painless, okay? The only time it becomes painful is when they're strangulated or, super inflamed. They're inflamed, strangulated, very swollen. But otherwise, they're very painless. The reason why they're painless is because they're made out of columnar epithelium, where there isn't any nerve endings, or the nerve endings aren't as much as in squamous epithelium. Okay. Mine isn't in pain though. If you're not in pain, if your hemorrhoids if you're not in pain and you have hemorrhoids, they're most likely internal hemorrhoids. Some people can have mixed hemorrhoids. Like, they can have both external and internal at the same time. Sadly. The pain is from anal cutaneous nerves. Yes, because it's more like if you notice, look at this. It's like skin level. Or look, it's the tissue is made out of squamous epithelium. It's really cutaneous, yeah. Alright, so that's why I told you guys this was important, that the epithelium, because it tells you which one is painful, which one is painless, and this is how we diagnose whether they have external or internal hemorrhoids, because if it's painful and you see it right there, that is external. But if they have hemorrhoids and it's not painful, then we know that it's internal hemorrhoids and it's just sticking out and you just gotta push it back in. Okay. How will they notice if they have internal hemorrhoids? Okay, usually patients complain of, quote-unquote, bukol sa puwet. May bukol ako sa puwet. Now, if they say, masakit siya, ang sakit, you start thinking of external hemorrhoids. Okay? And then that's when you have to do your examination. You inspect the anal area. And if you see any, engorged blood vessel, that is most likely an external hemorrhoid. Okay? And then if it is internal, they will say, I have a mass in my butt, but it doesn't hurt. It bled, but wala namang pain. Then it's most likely internal. But sometimes they can be in pain if it's, if it's really swollen and it's just sticking out there. Then yeah. CJ, thank you for the super. 99 cents. Yay. Thank you. Bleeding, yes. Hemorrhoids are made out of blood vessels. They bleed. Okay. So internal hemorrhoids have different grades. External doesn't, okay? External hemorrhoids doesn't have grades. If you have external hemorrhoids, you have external hemorrhoids. But internal hemorrhoids have different gradings. There's 4. Grade 1, or first degree, you just have an engorged hemorrhoidal pile. It does not prolapse, it's just there. Grade 2, prolapses, but it goes back on its own. Okay, it goes back on its own. Grade 3 prolapses. It prolapses, but it doesn't go back on its own. You have to push it back. You have to push it back in. That's grade 3. Grade 4 is when it prolapses and you can't push it back anymore. Okay? So it's really like varicose veins. Actually, yes. Yes, that is why the medication for hemorrhoids, for thrombosed or engorged or what do you call this? Swollen hemorrhoids is the same as the medication for varicose veins. The medicine they give is the same. They just give a different regimen. It's basically like varicose veins but in your butt. What if I make pilit my tae? Will I get hemorrhoids? If you make pilit your tae, Morphe, yes, you will get almoranas, okay? If you keep making pilit, the more you will get almoranas. Okay? Alright, so, what are the symptoms? Did I put symptoms here? Hindi pala. Okay. Symptoms of hemorrhoids. Okay, one is, yun nga, feeling of an anal mass. A mass in the anus. Pain on defecation or pain when pooping. Pain. Pain. Bleeding when pooping. Those are the most common symptoms. Fourth just looks awful. Yeah, I've seen the fourth. It's crazy. Usually the third and fourth undergo surgery, but the first two, it can be conservatized. Okay. Are they just supposed to be able to self-heal? Actually, yes, you can treat this conservatively. They can be treated conservatively. Conservative treatment! One of them we advise is a warm sitz bath or a hot sitz bath, okay, where you just dip your butt in warm water for like 15 minutes twice a day, something like that, or 30 minutes twice a day. Dip your butt in hot water. It feels good, by the way, when you dip your butt in hot water. I mean, para kang nagja-jacuzzi, diba? Pero sa puwet lang. Para kang nagja-jacuzzi, pero sa puwet lang. Diba? Masarap mag-jacuzzi. That's basically it. Okay? Drink a lot of water because you don't want to be constipated. You gotta be hydrated. Okay. And then, ano to? Your diet. Okay. High fiber diet. Or you just have to balance your diet because if your poop is too hard or you're constipated, you're really gonna develop hemorrhoids if you're always constipated. But at the same time, if you're always having diarrhea, lagi kang natatae, or tumatae, then you'll also get hemorrhoids. See, the most common denominator when it comes to risk factors in getting hemorrhoids is increased pressure in that area or the abdomen. So when you are constipated, you are putting pressure in your abdomen so that you can poop it out, right? At the same time, when you have diarrhea, your abdomen contracts to flush the poop out of your right? When you carry heavy things, you're also straining and putting pressure in your abdomen. When you're sitting down all the time, you're putting pressure in your abdomen, okay? Alright? So, that's the most common denominator. When you're coughing also, sometimes there is pressure in your abdomen. Like coughing chronically. Puwet kuzi. So, you're saying I should pour freshly boiled water. I said warm sitz bath, not boiling sitz bath, okay? Gamer posture. I'm pretty sure some of you have hemorrhoids already. It's common. Like, this is a very common disease, man. Another one is medication. So, if the hemorrhoid is bothersome already, like, if it's swollen and it's, like a grade 2 or grade 3, you can there are medications for it. They have ointments or cream, and there's also tablets. The same kind of medication you take for varicose veins. Okay. Now, what if conservative management doesn't work? You tried everything, but no, it's still there. Your butt's bleeding. It's painful. Then we go to surgery. And surgery for hemorrhoids is hemorrhoidectomy. Okay? There are two types of hemorrhoidectomies. One is the Parks or Ferguson hemorrhoidectomy or closed hemorrhoidectomy. And the other is Milligan and Morgan hemorrhoidectomy or open. Basically, what you do in this hemorrhoidectomy is you grab the pile, the engorged pile, or the the swollen pile. You snip it out or cut it out, and then if you're gonna do a Milligan Morgan, you just leave it open. You don't suture it. If you're gonna do a Ferguson, you suture it. So there's two types. And it is surgeon's preference which one they want to do. Okay, it is surgeon's preference which they want to do, which technique they want to do. Personally, for me, I do open type. Okay, because I feel like if you do closed type, they're gonna feel the sutures. So just leave it open and let it heal on its own. It'll heal on its own. Okay, it's just gonna feel weird, but it'll heal on its own. Okay. The thing is though, when we do this, we gotta make sure that there's no bleeding. Okay. Now there are other procedures for hemorrhoidectomy for the hemorrhoids. Okay, that there are other procedures for hemorrhoids. These procedures I have not seen personally or have not done personally. So the ones I've done are actual surgeries, the hemorrhoidectomies. And like this is a rubber band ligation, which is done in offices. I have not done this before, but I get the concept. You basically, like, this is the hemorrhoid. You have this instrument that you insert. You grab the hemorrhoid and then you put in a rubber band and then you wrap it around. It's like you tighten a rubber band onto the hemorrhoid and then leave it there until the hemorrhoid falls off. That's it. That's basically it. Okay? Doc, magkano pa magpa-anal sa abogado? Aba, tanungin mo yung abogado. Tanungin mo yung abogado. How well does the open heal? The open... Okay, the reason why also I go for open is so that the wound doesn't constrict so much. Because, you know, one of the risks that you want to avoid, or one of the complications that you want to avoid when you do a hemorrhoidectomy is anal stenosis or a constriction where the anus gets too small or too tight that they can't poop anymore. It happens. But the open type heals well. It heals well. It's okay. Because, you know, the body heals on its own. Kinda like Wolverine, but slower. Any wound you have heals. As long as you don't have any comorbidities or anything that will impair the healing. But it heals well. Okay? Wouldn't that be dangerous because it's a vein? Which one? It won't, because you basically clog the vein by using a rubber band. Okay, you basically sealed it. You imagine a vein and then you wrap it with like a rubber band, preventing it from preventing blood to pass through. That's what happens. It's a vein also, so the blood will go elsewhere, and it doesn't engorge here. The blood doesn't like pile up or like stay in this part. Okay. Now, this one I have not seen. I have not actually seen this. Okay? And, yeah, the ones I've only seen, unfortunately, is hemorrhoidectomy, like surgical. Probably these things are done by specialists like colorectal surgeons, and I am not a colorectal surgeon. Okay. Another one is infrared photocoagulation. Another one that I have not seen either. Okay, so it's basically you get an infrared coagulator, and then you just like you apply the light to it. Apply infrared light, and it reduces blood flow to the hemorrhoid, and it shrinks. Okay, I have not seen this done. This is something I pulled out from a book. From the surgery book, the Schwartz. Okay? I have not seen this in actual. So I am not able to really explain this one in full detail. Okay. What infrared data transfer? Another one I have not seen also is sclerotherapy, but I get the concept. You inject a certain substance to the hemorrhoid and it should shrink. It's also it's the same as what people do for varicose veins. They inject a certain fluid, and it should help with the varicose veins. But see, I'm a surgeon, so I have not seen this done. Or like I've only done surgeries, not bedside procedures like this. Okay. Okay. Anal fissure. This one is not I don't see this one that much. So anal fissure, para siyang sugat. Okay? It's like a tear in your anus. Imagine having a tear or sugat dyan sa puwet nyo, sa anus mo. That would hurt a lot because remember, this part of the anus is made up of squamous epithelium. There are a lot of nerve endings. So if you have, kung may gasgas kayo dyan, masakit yan. Okay? It's a fissure. So it's a tear or a wound distal to the dentate line. Usually, it happens when you're, again, constipated. When you poop, tapos ang tigas sa sobrang tigas ng tae nyo, parang bato, sinasugatan yung puwet nyo. Ganun yun. Or, you know, having diarrhea for so much. Having so much diarrhea that you, nasugatan yung puwet nyo. So, the problem with this, the problem with anal fissures is that it is very painful. So what is the when it's painful, the tendency of this is that you clench your butt. You clench, whether you intend to or not. It's just painful, so you just clench. So what happens is it causes spasm. Parang sumisikip lalo yung sphincter, diba? Because of the pain. It just gets tighter because it's so painful. Right? Yeah, it's very painful. Using bidet, yeah, it's very painful. Okay. So, another, ayun, ganun din. It can be treated conservatively. So, just pain management. Again, jacuzzi para sa puwet. Warm sitz bath. This. Just sit, dun. Alam mo, ganito, pag may, pag may fissure kayo or hemorrhoids, mag-jacuzzi kayo. Okay? If you're constipated, hydrate yourself. Take a high-fiber diet. There are certain medications you can take also. Okay? If I remember correctly, there are also other medications you can take to relax the sphincter. There's also, pain relievers. Surgery-wise, we do a sphincterotomy. Let's say none of the conservative management work. So we do surgery. if you have anal fissure for quite a while, to the point that you have the spasms is not controlled, what we do is we do a sphincterotomy, or a lateral internal sphincterotomy, where you partially cut the internal oh, not the inter you partially cut the internal sphincter. Partially only. Okay. So it's like you basically relax your the sphincter a little bit. Okay? I have seen this procedure a few times. But this one is usually done now by, I think it's usually done now by colorectal surgeons. So yeah, specialists. I'm scared. Oh no. Okay. Next. Okay, perianal abscess. Okay. Perianal abscess falls under the topic of anorectal abscesses. I did not cover anorectal abscesses that much, but basically anorectal abscess is abscess or nana that is found within these spaces. Like you can have an abscess here, an abscess here, an abscess here, an abscess here, abscess here. Perianal abscess just covers abscesses around this anal area. Okay? I did not put in the different types of anorectal abscesses anymore. But basically, those abscesses have the same treatment. Incision and drainage. You have to make an incision, drain the nana, drain the pus. Okay? Because the pus cannot just stay in there. It has to be released into the world. How does one have that anyway? Well, one cause is a diabetic person. Yung mabilis tawag dun? Tigyawat, parang ganun. People who easily get wounds on their bodies, usually they're diabetic. And then those wounds don't heal properly. You can also get this from... yeah, being unhygienic. You can also get this from being on the receiving end of another male. Okay? Okay. Now, yeah, the treatment is incision and drainage, depending on the location of the abscess. So I only covered perianal abscess, so it's really simple. Cut, release the pus, that's it. But the deeper the abscess is, the deeper the abscess is, the procedure is the same. You have to cut and release. The problem is that it goes deeper as well. So the cut also gets bigger. Okay. Alright, next. Okay. Fistula in ano. This one is usually caused by a perianal. If you have a perianal abscess, you have a 50... if you've had a perianal abscess before, you have a 50% chance of getting a fistula in ano. Okay? So, if you've had it before, you need to pray to the gacha lords that you're not the unlucky 50%. Okay. What is a fistula in ano? It is when you have an abscess. Okay? An abscess that heals, or like an abscess that makes a new tract outside. Like you can see here. Here, look. Nikita, I have to move myself. Hold on, let me move myself. Oh. Ano ba yan? Hindi ko kita. Ayan. See that? Over there. So, you have an abscess. It makes a tract, then the pus drains out. But what happens is there is a path from your anus, from inside your anus to the outside, through the skin. That's the problem. Okay. It Minecrafted. That's one way to put it. Yeah, it Minecrafted. Imagine, yeah, the abscess decided to make, you know, to mine its way out because it couldn't escape. So it like, okay, we gotta make ourselves a new path to get out of here. Tagal kasi ng surgeon mga opera. Tagal kasi ng seruhano. Tagal kasi pumunta sa doktor tong pasyenteng, tong si ano, tong si Bentix. Ang tagal kasi pumunta sa doktor. Ayan, gumawa na lang siya ng bagong path palabas. Okay. So, what is the treatment? Okay, fistula in anal can be very simple, but it can also be complicated. So, okay, wait, before we go to the different types of fistula in anus, there is a certain rule that we surgeons use when planning the operation for a simple fistula in anal. Okay? And this is something that is asked a lot in surgery. The Goodsall's rule. Okay? The Goodsall's rule. So this is a rule to help us like predict the trajectory of the fistula. Because what happens, see, when a patient comes to us complaining of draining discharge in the anus, and then we suspect a fistula in anal, what we usually see is the external fistula, right? A fistula kasi has an internal fistula and an external fistula. Okay? And then this bridge is called the tract. So we will know that they have fistula in anus because we see the external fistula. And what we need to do is find out where the internal fistula is. So this is where the Goodsall's rule comes in. So imagine this is a person lying on his belly. We call this the jackknife position, where they're bent over with their butt sticking out on the bed. Okay, this is the anus. You imagine a transverse line cutting the anus in half, the upper and the lower, or basically posterior and anterior. And if you have an external fistula, wait, let's see. Let's pick a color. Let's pick blue. If you have an external fistula over here, let's say here, dito siya, okay? The rule is that the internal fistula is in this position here. You just follow this. If the fistula is here, most likely the internal fistula is over here. Basically, it's radial, right? Straight track. If it's here, if the fistula is over here, or no, how do you? Oh shoot. If the fistula is here, kaya lang kasi medyo, okay, tama yan. If fistula is here, it'll be here, right? It's a straight tract. Now, if we're above, or no, now if the fistulas, the external fistula is 3 centimeters away from the anal verge, like here, let's say here. Let's say the fistula is here, yeah? 3 centimeters away from the anal verge. Then the tract is gonna be paganto siya. Going to the posterior midline, which is here. Okay? It will always curve this way. It's not gonna be a straight track like this. It's going to curve. So if we have a tract over here, I mean, if we have the fistula here, it's going to go like this. It's not going to be straight. Okay? If the fistula is... Now, if we're in the posterior part of the... If we're in the posterior area of the anus, so if the fistula is here, it's not gonna be a straight track like this. It curves also like that. That is Goodsall's rule. Okay? That's how we know where the internal tract, the internal fistula is. And we use this rule a lot. So when we see an external fistula, we just like, oh, okay, it's over here. That means the internal fistula must be over here. Okay, guys. Okay, chat. So do you understand? Any questions, chat? This is gonna be in our quiz later. Sa quiz nyo to mamaya. Okay, so if no questions, I get the idea. Not a quiz. Wala eh, may nagtanong kanina. Kaka-start lang ng stream, may nagtanong na kung may quiz eh. So sabi ko, sige, oo, meron. There is a quiz. I have a question, but it's about hemorrhoids. Yes, okay, what is your question? I like turtles. Okay, let's remove all the... Ouch, bagsak ako sa quiz. Ganun talaga. Does using an ice cube help with making internal hemorrhoids smaller? No. No, it doesn't. How, in the first place, how are you going to pop an ice cube inside your anus? Because that's internal hemorrhoids, yeah? It's what needs to be done is... That's why we have a warm sitz bath. It's actually warmth. Warmth that will help. Okay. It was really cold. Oh, okay. You put... oh god, you put ice there. You're supposed to use warm. That's why when you have hemorrhoids, the advice is warm sitz bath or hot sitz bath. You're supposed to put warm, warm water. Sayang, I took notes. But you were taking notes of this. All you gotta do... Spectral, all you have to do is search Goodsall's rule. That's it. It's also gonna be in your surgery book, okay? When you get to... I think, if I remember correctly, I think you have surgery... Second year. Second year is surgery. It'll be there. It'll be in your Schwartz book. You're most likely gonna be reading Schwartz. It's there. Don't worry about it. Don't worry about this so much yet. I think first year your focus is anatomy, physiology, histology, biochemistry, and yeah, yung basics, okay? Spectral. First year you're gonna focus on basics. Second year is when you start getting a little more clinical. So, this thing, Goodsall's, you're gonna learn this in second year. Okay? Second or third year. Alright. Next. Okay, here we go. There's different types of, again, there are different types of fistula in ano. Okay? So, there's the extrasphincteric, the suprasphincteric, transsphincteric, intersphincteric, submucosal. Submucosal is just there. It's very shallow. Intersphincteric is the tract. Okay, this is the internal This is the internal fistula. It goes in between the internal and external muscles. Transsphincteric, basically the tract crosses both the sphincter muscles. Suprasphincteric, it goes through the internal and then over the external sphincter. And then extrasphincteric is where the tract starts, like all the way up here, and then just there. Skips over to the, doesn't go through the sphincter muscles. Okay. So, if you're gonna do with submucosal, if you're dealing with submucosal and intersphincteric fistulas, all you have to do is a fistulotomy and fistulectomy. A fistulotomy is when what we do is, for example, here. For example, we're dealing with a fistula here. The internal tract is here. The internal fistula is here. The external fistula is here. We just cut it open. We expose the tract. Okay, we hihiwa kami. We make an incision, open this up, expose the tract. In a fistulotomy, we just burn the tract. Okay, with the electrocautery. In a fistulectomy, we excise the tract. So we're gonna have to like excise that entire bridge. And then we don't close it up anymore. We just leave it like that. Okay? That's the difference between a fistulotomy and a fistulectomy. Okay. Now, if we deal with the transsphincteric fistulas, it gets a little more complicated. So you can do a fistulotomy. There's also other sphincter preserving procedures. There's also what we call a seton placement. Okay? Seton is when you put an object through the fistula. Like, for example, there's two types. There's the cutting and non-cutting seton. In a cutting seton, you put a suture. A suture through here. Like, you put it through the tract like that. And then what you do, so it's like needling a thread. You put the thread or the suture through the tract like that. Okay. So wait, let me draw it. Blue. I know, not blue. Green na lang. Or orange. Ay, blue, orange. That's a good one. Black na lang. Okay. Kunwari, ito. Put a thread. Ito yung internal, ganyan. Transsphincteric, pag ganun. And it goes out here. And then you tie it together. Okay? You're gonna tie it, and then you're gonna tighten it every week. You're going to, when you tie it, it has to be really tight. And you tighten it every week. So what happens? What is the purpose? The purpose of that is that you want the thread. The thread is gonna cut through the fistula. It's gonna slowly cut through, so while you're healing, it's going to cut through the muscle like this. The more you tighten it, and then your body's gonna expel the suture. It's going to go until you're gonna tighten and tighten until you can remove the suture. Basically, parang ganun. It's kinda hard to explain it, but yeah. What this does is you prevent actually damaging the muscle. You don't want to damage the sphincters, because if you damage the sphincters, they might have incontinence. So like every week, my follow-up, sinisikipan to. Parang ganun. Okay? I've had a patient where I had to do that to a patient before. He would follow up every week. And I would have to tighten that suture every time. Until one day, I tightened it and it broke. I'm like, oh, okay. This sounds uncomfortable. It actually is. He would come and say, it's uncomfortable. Like, yeah, I know, but we gotta do this. Okay. Alright, and refer to a specialist, so colorectal surgeons. Because there's some transficteric fistulas that are like too high up or something, that it gets a little more complicated. Okay. Suprasphincteric also, you also do a sit-on placement, so just to avoid injuring the muscles, or also refer to a specialist. And whatever they do, I don't know how it's done. There are like, I think, wait, I have a slide here. Hold on. Refer to, if it's extrasphincteric, you refer to a specialist also. So this is me being a general surgeon. I am not familiar with the other procedures that the colorectal surgeons do. Like here, there is a whole table for it. These are like for example, submucosal. It's superficial. All you gotta do is a fistulotomy. Okay? If you have an intersphincteric fistula, all you gotta do is do a fistulotomy also. It's pretty simple. That's it. Okay? Now, if it's transficteric, this is where you have so many different treatment options, okay? Sometimes you can do a fistulotomy. Sometimes you gotta do a seton. And then there's also these. If more than a third of the sphincter is involved, you have to do sphincter preserving procedures. Now, these things, I have no idea how to do these. Like, I don't know how to do a lift procedure, and then there's a VAFT. AFP, trapezius perfect. These are recent procedures that I am not familiar with. Probably now, maybe in med school. In the med school now, they're teaching this. Because these are fairly new. Like, only a few years ago, parang ganun. I'm in like, only like, what, 5 years ago? The heck? Stuff they didn't teach in med school. Yet. Okay? So... But these are some things that I will have to know about. Especially when I'm gonna take my diplomate exams. But yeah, I did not learn. These are stuff I have not seen. Okay. Medical science has come so far. Yeah, it has. They have different procedures now. Suprasphincteric, what do you call it? Suprasphincteric fistula. So it cuts through the internal, like I said, it cuts through the internal sphincter and then over the external sphincter. It actually cuts through also this, which is called the puborectalis. Oh, wait. And the levator animal. So another pelvic muscle. And then you refer to a specialist and they do these other procedures that I am not familiar with. Okay? But the thing is, at least, and also for extra sphincteric, it's the same thing. They use these procedures. The good thing is that these kinds of fistulas are pretty rare. As you can see, the prevalence, these are more common. But when you go to suprasphincteric and extrasphincteric, it's like 20%, 5% of cases. So yeah. Okay. These are especially hard when the patient doesn't have a well-controlled inflammatory... Yes! Yes, that's true. So, I think... Is this... Yeah, that's my last slide. Okay? Benign anal diseases. That is part 1 of going anal. The second part will be... I'll cover cancer. Okay? And cancer, we will be a little more in-depth with that one. So... You guys have any questions? Part 1 lang eh. Yes, that's only part 1 because I decided to separate cancer. Cancer is gonna be a whole new different topic. Like, I mean, part 2 of the topic because we're gonna be a little more thorough with anal cancer. I will talk about anal cancer more thoroughly. Because I can't squeeze it in to this stream. Because when I do medical education stream, I like to keep them short, less than 2 hours at least. I don't want to keep it long. Yeah, you're gonna go deeper. Okay. If there are no questions, mag-quiz na tayo. Quiz na tayo. Proctitis and condyloma. Condyloma is like a... I did not cover condyloma. I covered more the most common ones I've run into. Anal diseases. So I did not cover proctitis because that one is more like that one is more non-surgical for the time being and then you use it's like you can treat it conservatively unless it gets really severe. But that's a whole new proctitis. That is like a little more complicated. And condyloma, I did not talk about condyloma. I talked more about hemorrhoids because that is so common. Fistula and anal is very common. Anal warts, I've seen so many of these, so that's why I talked about it. Yeah, it's an infectious disease, right? So it's more like medical. So I just cover what I commonly see. Especially there, hemorrhoids, fistula, perianal abscess. Fissures, actually, I've only seen a few compared to those. But yeah. Hello, Lebe! Hello. But yeah, part 2, I will talk about anal cancer. So, I think what I'm gonna do is the next medical education stream will be about the cancer, anal cancer. So I will try to be thorough with it, including like the chemotherapies and stuff, and then the surgeries done. But as there are some new procedures that they do for anal cancer that I have not done as a general surgeon yet, even in residency. Like, most of the surgeries I would see for anal cancer is an APR or an abdominal perineal resection, which is a major surgery. I will talk about that next time. You got a YOLO with a quiz. You guys want... You're the ones who asked me for a quiz. It's easy anyway. Ay, teka. Wait lang. Oh, I forgot to set my... Hold on. Hindi ko na wala na set to. I did not set this. Okay, there we go. There we go. What color should I use? Let's use red. Red. I believe in us. Okay. Alright, class. Get 1/4 sheet of paper. 1/4 sheet of paper. How does one do early... What's this? How does one do early find an intervention on anal carcinoma? If I remember correctly, part of what's difficult is that it tends to be found out late. Yeah, I will talk about that in the next stream. That's why I divided this into 2. So I discussed like most common benign anal diseases that I encountered, and then the next one will be I'll cover cancer. Definitely. But in general, cancer is in general, cancer is is hard to detect if you don't, you know. It's not easy to like diagnose cancer. Unless you undergo a lot of like, you know, you're gonna see your doctor, they have to examine you, they gotta ask your history PE, and then you have to undergo a series of tests. Like, there is not one diagnostic that will tell you, ah, this is cancer. It's something that you have to look at as a whole. Like, you can have a CT scan done to you, and then they will see a mass somewhere. But you can't confirm that's cancer yet. Because it also depends on your symptoms, your history, and even a biopsy. Can they check for that? When they do a digital rectal exam, you can detect or screen for cancer in a digital rectal exam. For at least for anal cancer. Anal or rectal cancer, you can screen for it. But even if you feel a mass in the anus or the rectum, although you consider cancer, you can't be 100% sure it is until you work it up. That's why it is not that easy to, like, you know, diagnose it. Okay, also, sorry, latecomer po. May consideration po ba for the... Ay, nako, mga late. Okay, wait. Latecomers. Oh my god, it's hard to write. Okay, mga latecomers. Latecomers, automatic F. Automatic F na yung grade nyo. Wala! Late. Late. Doc, can you immediately get infected by HIV after an intercourse? There is a time frame for that. There's a time frame for that. That's why when you suspect HIV, like even on a needle stick injury, you gotta go straight to the to get screened and start treatment, or like a prophylactic treatment. But there is a leeway, or like you don't develop like. You don't develop like symptoms or whatnot right away. There is the virus has time to like multiply and all that. It's not but this part, the pathophysiology of that is not my forte. I don't really handle much HIV. The only HIV patients I've ever handled were the ones who had like surgical complications that needed surgical treatment, like anal warts and fistulas and other things. Most anal cancer, anal cancer is very prevalent in those who have HPV. It's a very important what do you call this? Risk factor. Like, every wart you have is probably, like, every wart that you get in the genitals or in that area is probably HPV, man. Ugh. What's this? Kasali ako sa latecomers, 3 PM na nakapasok sa stream dahil natulog. Okay lang, F. Paminsan lang yan nangyari sa college. Alright, let's go! Let's go, guys. Number 1. Where's my... Number 1! Come on there. This is very easy, okay? Okay. Number 1. What do you call the hemorrhoids? What do you call the hemorrhoids that are... Hemorrhoids... that are above the dentate line? Yeah, what are the hemorrhoids above the dentate line? The clue here is they are painless. Internal, angry hemorrhoids. What the? Interior hemorrhoids. Interior, that sounds like a freaking... Interior hemorrhoids sounds like a... Parang ano? That sounds like something you put in inside a room, man. Interior hemorrhoids. Imagine having hemorrhoids inside your room. I got interior hemorrhoids. You got interior of your car, interior of your house. Imagine your house having like a little hemorrhoid. Okay, it's internal hemorrhoids. Okay, nice. Okay, question number 2. Question number 2. So, the answer number 1 is internal hemorrhoids, right? What is the epithelium? Epithelium, or the cell lining. Epithelium of internal. Hemorrhoids. Skin. What? Hindi lang skin. I'm already saying epithelium, man. I mentioned it already. Come on. Cuboidal. Ano pa? The surface. Yeah. What is the epithelium above the dentate line? Below the dentate line, I told you, right? That's the reason why that type of hemorrhoid, the external hemorrhoids, is painful. Because it's below the dentate line, because it's made out of squamous epithelium. So what is the internal hemorrhoids? Columnar. Ayun, Spectral got it. It's columnar. Columnar. Yay. Alright, it's columnar. Okay. They have less to no nerve endings compared to external hemorrhoids. That's why they're painful, because they're made out of squamous epithelium, and there's like lots of nerve endings there. That's why your anal fissures hurt, by the way. I gaslit myself twice. Good luck in med school, by the way, Spectral. You're gonna need it. Med school is really hard. I barely survived med school, man. Okay, number 3. Okay, number 3, oh, okay. Give me, let me think. What is the surgical treatment for hemorrhoids? Napakadali naman yun. Surgical You don't need to be that specific, by the way. I asked you, I told you, like, there's two types, right? The open and closed treatment. Surgical of hemorrhoids. Just give me, like, the general surgical term for treating hemorrhoids. Cautery. Hindi naman cautery. Hindi naman cautery. Cautery is for something else, man. Cautery is for the warts, not the hemorrhoids. Hemorrhoids are larger. Yeah, it's for warts. Hemorrhoidectomy. Yeah, it's hemorrhoidectomy. Hemorrhoidectomy. Remember that? Okay. Remember in medicine, we have like certain terms. When a word ends in ectomy, it means to remove. If you say otomy, it means to like put a hole in or to open. It's to open, put a hole, something like that. So hemorrhoidectomy means removal of the hemorrhoids. There is no hemorrhoidotomy because you gotta remove it anyway. Okay. I'm bad at remembering terms longer than 4 syllables long. Oh god. For skinectomy, bruh. Okay. Number 4. Hemorrhoid indomie. Ginawang noodles. That is noodles. What the heck? Okay. Alright. Okay, number 4. Number 4. What is... Okay, give me the grade. Okay, grade of internal hemorrhoids. Wherein grade of internal hemorrhoids wherein the hemorrhoid is prolapsing and you have to push it back in. Yeah. Must push back in. What grade is that? Or degree? Must push back in hemorrhoid. Must push back inside. Imagine having a soulectomy. Soulectomy, oh my god. Oh no. Your soul is mine. God, Mortal Kombat. Let's see. Grade 3, grade 4, master grade. Master grade, what the hell? Grade 2, grade 2. Alright, only one person got it right. Grade 1 na lang di nasasagot. Okay. It's grade 3. It's grade 3. Grade 1 is it's engorged or enlarged. Grade 2 it prolapses but it goes back in. It goes back in on its own. Grade 3 you have to push it back in. Grade 4 you can't push it back in. That's basically it. Okay. Oh, okay. Alright. Eto, last question. Right, let's go we're gonna talk. The last question is about fistula in anal, okay? Fistula in anal. How do I... Good Sal's rule. I'm gonna draw it. Wee. Okay, ito yung puwet. Magdodrawing lang ako ng puwet, guys, ha. Ito yung butas ng puwet niya. Okay, imagine, ito yung butas ng puwet niya, okay? This is your butthole. Okay. Let's see. This is posterior, anterior. So this is the back, this is the front. Okay? Alright. Let's say your... Okay, let's say we have an external fistula over here. Okay, this is the external fistula, okay? Over here, it's over here. Okay? That's the external fistula. And this external fistula is... Wait. Let's say this external fistula is around, 3.5 centimeters away from the anal verge. Where is the internal fistula? Where is the internal fistula? Oh wait, I'll give you guys a clue. Wait. Where's the... Okay, where's the thing? Okay, this is the transverse line, okay? Remember that there's like a transverse line like this. Okay. Okay. The distance between the external fistula is 3.5 centimeters away from the anal verge. So where's the internal? Let's see. 3 cm away from it. Curves above the hole, my choices. You have two choices. You have two choices. Your choice is, it's either here, 3.5 centimeter, the internal fistula is, in the same area, 3.5 centimeters away, or it is on top over here. What is this? On the posterior midline. On the posterior midline. This is the midline. Follow the curve. 3 cm away, curves above the hole. Above the line? Where above the line, though? Okay. I'll give you... Ito na nga. I'll give you choices, Jesus. Okay. Ito yung choices nyo! Ito ulit. Okay. A, ito. A, it's over here. Like right here, okay? A. B is here. C is here. O yan, ha? So A is like, it's just directly across the X. B is it curves here, pa ganon. C is it curves, it curves or goes straight here to C. A for anal. Since it is below, then it is straight. Okay. Okay, guys, I'm gonna go back to the... I think mali notes ko. Okay. Bali kayong lahat. The answer's B. The answer's B. Bayan, bali kayong lahat. Alright, look. Good Sal's rule. Good Sal's rule, if this is your external fistula, if the distance between this and the butthole or the anus is less than 3 cm, it's just like if it's here, then you just follow a straight line towards the anus. That's where the internal fistula is. But if it is 3.5 centimeters away from the anus and it is located anteriorly, it curves. Okay? It curves to the posterior midline. Okay? Not to the side. Not here. It curves to the midline. If your fistula is here, let's say your fistula is here, and then this one is 2 cm away. Where's the internal Kaya, eto, may fistula ka dito, may external fistula dito sa posterior, 2 centimeters away from the anus. Where's the internal fistula? Is it in is it in letter B or is it somewhere else? Yung mga nagsagot ng sinagagayan. Eto. Fistula is here, 2 centimeters away from the butthole. Is it going to be in letter B, the internal, or is it somewhere else? Somewhere else? Okay, yeah, it's somewhere else. It's basically a straight line. No, wait, it's B. Sorry, it's not. It's B. Remember that the straight line only happens when it's anterior. But as soon as the fistula, external fistula, is posterior to this transverse line, no matter how close it is to the anus, it'll always end in B. Okay? But if you're here, if the fistula is here, as long as it's less than 3 cm, it's gonna follow a straight line. But if it is more than 3 cm, it's going to curve to B. So if fistula is here, it's gonna curve like this to B. If it's here, it's gonna curve to B. If it's over here, this far, 4 cm, it's gonna curve to B. If it is here, 2 cm away from the midline, away from the anal verge, it's gonna curve to B. Okay, it's not gonna be a straight line. It's gonna curve pa ganun, pataas. Okay. Basically, that's it. The higher the distance, the more curve. Yes! Yeah, you could say that. Or, as long as if it's in the anterior, the farther away it is, it's going to curve. If it's posterior, it will always curve. Okay? If it's anterior, less than 3 cm, it'll be a straight line. Ma'am, I'm so glad I don't have to deal with these. Big thanks to the surgical friends deal with the end. Yes, oh god. Yes. Don't worry, when I was a med student, this confused me so much. But then, you know, when you go through surgery residency and you see a fistula and anus all the time, you end up memorizing this thing. Good Saul's rule. It is confusing. I understand it's confusing at first, but yeah. I mean, for surgery, for me, as a surgeon, even I get confused with infectious disease stuff. Okay? we have our own specialties. We get confused with other people's specialties. Like, like antibiotics. Pretty sure we as surgeons were like, hey, just give this guy coamoxiclav. Start this guy on levofloxacin. And then, oh my god, that reminds me. I remember, like, I would... I'd have to, like... I think... Well, no, it was a urologist. A urologist was to me, like, before was like, okay, start levofloxacin. Start levofloxacin on this patient. And I'm like, okay. And then I start writing the order. And only to get cock blocked by an infectious disease. Like, and they just have, why are you ordering this? And I have to, okay, I will tell my boss. The infectious disease is asking why are we giving levofloxacin. We have our own demons. Yeah, it's a thing, but yes, guys, it's a thing in, like, there are some antibiotics that have to undergo, and they need approval from the infectious disease to prevent antibiotic resistance. There are many such yeah, you know, I, like, every time it happens, like, we have to go through infectious disease first. We gotta talk to infectious disease. Brother, I got confused when I saw the thumbnail. We're going anal. We just talked about anuses for 2 hours. Okay. Okay, where is it though? Hold on, I am going to... There we go. Alright. Careful with the ID police. Yes. I know. I've had my own, I had my own weird experience with an infectious disease, doctor. Well, no, not really an infectious disease doctor, but, like, the family's doctor was an infectious disease. Oh my god, I'm gonna share this story. Okay, I gotta share this story to you guys. So... So I had this, when I was like a first-year resident, okay? I was only a first-year resident. And then, the nurse called me, to help with a Foley catheter insertion, okay? A Foley catheter is is a tube that you insert in the urethra, so that and it goes straight to the urinary bladder, so you drain the urine in a bag. Okay? And then, so I'm like, okay. So I go up there like, this is just a Foley catheter insertion. Ang dali-dali lang to, madali lang, okay? I just go up there, and then, so I tell the nurse, okay, give me the materials. The nurse warns me though. For some reason, I didn't know, okay? I didn't know. Like, she warns me, but I didn't think much of it. Like, I didn't care. She said, Doktora, yung main attending nito, the main attending for this is Dr. blah blah blah. And I'm like, oh. And I didn't know who that was. I'm like, oh, okay, whatever. Something to it. I go inside. And then I prepare, like, you know, how to put a Foley catheter. You have to sterilize the area. You clean the area with betadine, okay? So what we do is, we clean the crotch with betadine, including the penis, okay? Because it was a male patient. A male patient. So betadine, like usually we just put the betadine on the crotch area. Sometimes yeah, just the crotch area, okay? And then so I did that. I get the I get the catheter, I start putting gel in it, and then I'm about to put the catheter in. Okay? I'm about to put the catheter in, and then the relative, I think she was the daughter, she yells at me. She yells at me, okay? She gets angry at me. And she's like, Doktora! Hindi ka ba marunong mag-insert ng Foley catheter? She gets angry. Like, Doctor, do you not know how to insert a Foley catheter? She does that to me. And I'm like, what? I was like, wait, what? I was confused for a while. I was like, wait, what? And she's like, she says like, I am also a doctor. Okay, she's also a doctor. Apparently she's also a doctor. She's a psychiatrist, by the way. She's a psychiatrist. And she's like, di ka ba marunong mag-insert ng poly catheter? And I just look at her really confused. And I'm like, wait, what did I do wrong? I did everything right. I haven't even done anything yet. and then she's like, Bakit ganyan ka mag-insert? Why are you doing it that way? And then I was like, I just sterilized the area with betadine. So I just explained what I was doing. Like, oh, I just cleaned the area with betadine. And then I'm wearing sterile gloves. I was wearing sterile gloves. I cleaned the air. I made sure also that when I cleaned the area with betadine, I used different gloves. So I cleaned it with like clean gloves, betadine, and then I changed to sterile gloves. And then I was holding the penis, and then I put gel on the catheter, and then I just explained it to her, and she was like, that is not how you do this. Is that how you prep the patient for Foley catheter insertion? I'm like, what? And then she just really gets angry at me, and she's like, who is your senior? Call your senior now. I'm like, and I was so confused. I'm like, what the hell, man? I was so confused. And so I called my senior. I was like, dude, I call my senior. I'm like, I don't understand what's happening. She says I'm inserting the catheter wrong. I'm like, and my senior was asking me, agitated, like, what? Do you not know how to insert it? I'm like, I know how to insert a catheter. I'm like, I've been doing this since med school. I'm like, no one has ever complained except now. Like, no one has ever complained except now. And then, so she goes up there, and then she asks the nurse, like, okay, what's going on? And then the nurse tells her, kasi yung attending nito si Dr. blah blah blah. And then her eyes widen, and she's like, she looks at me, and she's like, kaya pala, that's why. She's like, because their consultant was apparently the main attending was an infectious disease consultant that is very strict with sterility. Like, OA siya daw, OA. So apparently, so we went into the patient's room, and then so the psychiatrist's daughter started like getting angry, scolding me and the senior. And it's like, etong junior nyo, your junior resident doesn't know how to insert a Foley catheter properly. Parang hindi naturuan. Like, I was like, what the I wanted to like freaking speak up, like, what the hell are you talking about? What the I've been doing this. And you see, what she wanted, or what she was used to, the reason why she got pissed off is what she was used to. She was like, hindi ba, diba, pag nag-prep kayo ng pang-insertion ng Foley catheter, ganito ang prep nyo, diba? Yung betadine dapat from pusod hanggang upper knee or lower thigh. I'm like, what? I was like, what? What? I have to put betadine from the freaking belly button area all the way up to the lower thigh just for a freaking Foley catheter insertion. I was like, what? I'm not operating on this. I'm not doing surgery. I'm just inserting a catheter. I was like so confused. I'm like, that's it. I know, right? It's crazy. And I was like, what? So my senior was like just apologizing on my behalf. Like, sorry po, doctora, sorry. And then she was the one who did it. So she prepped the patient the way she wanted him to be prepped and then did the insertion. And then we were like, sorry, and I left. And I was like, to my senior, I'm like, what the fuck? I was like, are you kidding me? That prep she wanted was like for a freaking hernia surgery. Yeah, apparently the infectious disease attending, I think he does it that way. So the daughter, the psychiatrist's daughter, got used to that. So when you do a Foley catheter insertion, it has to be that way. It had to be like that. Okay, so we are going to insert a Foley catheter. So first we will submerge on this barrel. I was like, so, I swear to God, that was the most ridiculous thing I have ever experienced. Like, what the hell? I got reported because of that. I was like, what the? I had to like explain myself. Like, yeah, she got angry because she wanted me to prep the entire patient. Like, probably just pour the whole bottle of betadine on his crotch and legs. God, I hate that. I hated that. I hated that girl. You know, after that, I hated that psychiatry consultant. She was, oh my God, never again. I still remember her name, and I'm never gonna. I never want to like encounter her. Iodine baptism. Yeah, never again. Like, I remember, I can't forget her name, man. The name of that doctor. Like, if I ever have, like, if I need to refer, or if I have, like, you know, someone who's crazy in the family and needs a psychiatric consultation, and then that name comes up, I'm like, never. No. No. God. That was like crazy, man. Okay. Anyway, oh my God, it's 2 hours and 11 minutes. We're good. We're good for today, guys. We're good for today. Can you refuse to do surgery? I can refuse her as a patient. Pass her to your junior to that was like, no. God. Anyway, yeah, we're good for today, guys. So thank you for coming to my stream. I hope you guys learned a lot. Stay tuned for part 2 of Going Anal, probably next week. I will talk about anal cancer. Let's see. My next stream will be on, I think tomorrow, yeah? I think tomorrow. Yeah, my next stream is tomorrow. I will be playing Doom on Twitch. I'll be on Twitch, guys, okay? Tomorrow on Twitch, 2 PM, Doom the Dark Ages. And then Friday night will be horror, Pisonet. The rest of my streams will be on Twitch. Colon cancer? Yeah, I will cover colon cancer in another streams. We're doing anus first. So, I'm definitely gonna do colon cancer. I'm gonna go more in-depth with that because colon cancer, there is a lot to talk about in colon cancer. We learn naman kahit pagsak sa quiz. Thank you for your class on butt hurt and ass blast. I got 0 out of 5 yan kasi pokari eh. Late ka nga. Tapos ano, di ba late ka? Ay, hindi ka pala late. Hindi ka nakikinig. Alright. So yeah, Otsupon. I'll see you guys on Twitch tomorrow. Goodbye.